Good afternoon or good morning for those of you joining from the West Coast. Thank you for joining us here. My name is Lenora Johnson, and I direct the NHLBI Office of Science Policy, Engagement, Education, and Communications. We're excited to welcome you to our September webinar series. The series is called Sickle Cell Awareness Month, Sickle Cell Science, the Path to Progress. With this series, our aim is to address some of the educational and information needs that have already been shared with us by members of the sickle cell community. Today, the webinar is titled Serving the Sickle Cell Disease Community Here and Abroad. We aim to give you an overview of some current activities regarding dissemination and implementation efforts in and across the United States as well as worldwide. We hope to share with you how we're building bridges to bring innovations for those who are affected by sickle cell disease across the globe. Our speakers joining me today are Dr. Keith Hoots, who is the Director of the NHLBI Division of Blood Diseases, Dr. Cheryl Boyce, who's Branch Chief for the Implementation Science Branch within the Center for Translational Research and Implementation Science here at NHLBI. And then also Dr. Kim Smith-Whitley, who directs the Comprehensive Sickle Cell Center at the Children's Hospital in Philadelphia. She's also a member and representing the board for the Sickle Cell Disease Association of America. I would like to ask that presenters please mute yourselves whenever possible or whenever you're not speaking. For those that are joining us as listeners, if you have any questions throughout the session, please feel free to send them to us. You may use the chat feature on the WebEx and send your message to the host as well as the panelists. You can also send questions if you're listening online to NHLBI-NEWS, that's NHLBI News, at nhlbi.nih.gov. and we'll receive them through that email account. We'll hope to take some time toward the end of the presentations for your questions and answer them as they come in. As a reminder, today's webinar is actually the first of 4 this month that we will host on Wednesdays from 1 p.m. to 2 p.m. Eastern Standard Time. You may find more information about the other sessions that are upcoming by searching for Sickle Cell Science Path to Progress on Eventbrite or on the NHLBI website. Thanks for joining us, and at this time, I'll ask Dr. Keith Hoots to participate.
Thank you, Lenora. It's a pleasure to be here with you. Today I'm going to talk about NHLBI sickle cell disease programs in sub-Saharan Africa. Let me begin by saying that we had no such programs in sub-Saharan Africa in sickle cell in 2015. So the programs I'm going to mention to you today are relatively new for us, although that does underestimate the progress that's been made primarily by our investigative teams in Africa itself, which I will emphasize in several occasions, because one of the philosophies that we undertook when we began in Africa was that we were going to support African investigators to do sickle cell in Africa. So let me begin by just, as I'm sure many people on this call realize, the prevalence of the disease is so much larger in Africa than in most places in the world. There are high prevalences in India and smaller prevalences in the rest of the world, including the Middle East, Europe, and North America. To put that into perspective, there are as many babies born with sickle cell, by estimate, in Nigeria alone as there almost are total people with sickle cell in the United States of America. And this represents more than 75% of all sickle cell births in the world. However, as you are probably also aware, healthcare resources are challenged in these areas. And it's estimated by the World Health Organization that as many as 50% or greater of affected children die before the age of 5. And a lot of what we're aiming to impact there is to change this paradigm so that we get survival, long-term survival, and better care all the way across the age spectrum. One of the ways that this will happen is if we take research that's present in the developed world and extend it with investigators in the developing world who know the landscape better than anyone because they're there on the ground. So now, you know, I said that we had begun as recently as 2015. At the present time, shown by the red stars here on the graph, we're in 9 countries, plus in 11 cities across sub-Saharan Africa, in 4 distinct programs that are really 3 and 1 that has 2 components, and I'll talk you through that. These countries include Angola, Cameroon, the Democratic Republic of Congo, Ghana, Kenya, Nigeria, Tanzania, South Africa, and Uganda. There are 3 programs that I will take you through. The first one is called the Sickle Cell PanAfrican Consortium and the associated data coordinating center for that program. The Sickle Cell Consortium goes under the acronym of SPARCO. It is an NHLBI grant made to the principal investigator, Dr. Julie Makani, in Dar es Salaam, Mobile University there in Tanzania, with sites in Abuja, Nigeria, and Kumasi, Ghana. In a separate grant, but part of the same program, we are presently funding the Sickle Cell Anemia Data Coordinating Center in Cape Town, South Africa, with Dr. Ambrose Wankum as the PI, and the co-principal investigator is Dr. Nikki Mulder there. Our goals are, and their goals, are to develop a red cap sickle cell disease registry with a total of, in aggregate, of 13,000 subjects over the first 4 years of all ages, to create a shared database with phenotype definitions and ontologies, and I'll come back to this, and a regionally appropriate clinical sickle cell disease management guidelines that can be employed in these 3 countries and then in the future more extensively geographically. So we will then, I'll talk to you about, give you an overview of several of the other programs and come back to this one. The second program is called REACH, Realizing Effectiveness Across Continents with Hydroxyurea. This is a R01, cooperative agreement. It began as an R01 with Dr. Russell Ware from Cincinnati Children's Hospital and his collaborators in Uganda, Kenya, and Angola, and the Democratic Republic of Congo. The data coordination for this program is in Cincinnati. The principals, there are co-principals at each of the sites in Africa. We began funding this in approximately the 3rd year of the R01 so that they could extend the follow-up. The purposes of this program is to recruit 600 children ages 1 to 10 to explore what is the optimal dose of hydroxyurea that can be maintained in a challenging cultural and geographic location without the ability to do on-site pharmacokinetics. There are pharmacokinetics, however, as part of this, and they are performed with specimens obtained from children in the respective countries and sent to Cincinnati, and it's from this that they've been able to ascertain what's the maximum tolerated dose on average for children between the ages of 1 and 10 years of age. The drug itself is being altruistically supplied by Bristol Myers Squibb in capsule form that's been tested for hematologic toxicity to establish safety, feasibility, and the benefits thereof. There's also looking at individual responses and correlating those with the pharmacokinetic studies done in Cincinnati. And they are gathering data, just as the first program, in a REDCap data system. The idea is to teach all African physicians that have a cohort of sickle cell patients how to administer hydroxyurea in this setting and to establish a future research infrastructure. The results of this effort were presented at the American Society of Hematology in December of 2018 and published in the first edition of the New England Journal of Medicine beginning 2019. In the article you see in front of you, the lead author was the investigator from Uganda, Dr. Leon Chilolo, and you can see that the collaborators include individuals from across the REACH investigators. The third program I want to mention is the Sickle Cell Disease Genomics Network of Africa, or SickleGen Africa. This program has as its PI Dr. Solomon Afori Akwa, who has dual appointments at the University of Ghana in Accra, as well as at the University of Pittsburgh. This is a program that grew out of H3 Africa, a program that is a collaboration between the Wellcome Trust in the UK and the National Institutes of Health here in the US, and specifically coordinated for the broader program by the National Human Genome Research Institute, but for the purposes of sickle cell is coordinated by us in NHLBI. And the sites here are 2 sites in Ghana, Kumasi and Accra, 2 sites in Nigeria, 3 sites in Nigeria, Abuja, Kano, and Lagos, Luanda in Cameroon, and Dar es Salaam in Tanzania. And the goal here is to build capacity for genomic research in Africa, to perform 3 studies to test the hypothesis that genetic variation influences the body's defense against hemolytic disease and organ damage in sickle cell, and to study sickle cell disease cohorts from existing sickle cell disease cohorts that have already been recruited, a total of 5,500 subjects with children and adults. And then to establish administrative, molecular hematology, and transgenic sickle cell investigative teams, as well as to employ community engagement and to train future science leaders in Africa. This is the whole overall program in H3 as the combination program from Wellcome Trust and NIH is to facilitate an African-based research approach for the study of genomic and environmental determinants of common diseases, in this case sickle cell, because it is common in Africa, with the goal of improving the health of African populations. Specifically, this will involve increasing the number of African scientists in the field of genomics and population-based research, establishing collaborative networks of African investigators who are pursuing genomics-based disease-oriented projects, and to create and expand infrastructure for genomics research, including bioinformatics and biorepositories. And you can see some of the projects that H3 has funded, but I've highlighted in yellow the specific one that we're here to talk about today that I'm summarizing for you, which is the sickle cell program. Now I want to come back to the SPARCO and the SADACC or SADAC programs that are out of Dar es Salaam, Abuja, and Accra. This is a program that we fund primarily. We make the grant directly to the investigator, Dr. Julie Makani in Dar es Salaam, Tanzania, and subcontracts are then led by her institution to the other sites. The coordinating center grants are made directly to the institution of University of Cape Town in South Africa with Dr. Ambrose Wacom, as I alluded to before. Here the goals are somewhat different from the first 2 programs. They're to develop a REDCap sickle cell disease electronic database, which is well on its way to development. They will share database elements and harmonize, and this is really important, sickle cell disease phenotype definitions and ontologies, which I'll give you a little report about their progress in just a moment, and also to create regionally appropriate clinical guidelines, which they are well along in the They're now entering years 3 of a 4-year project, and the expectation is that we will move this program forward from the original landmark program that was established in 2017. So in 2017, we awarded the grant in April, and it goes through March of 21, and as I said, it is our intention to build on this infrastructure going forward. So far, they're well along in establishing a registry and a database system. They've harmonized phenotype definitions and ontologies in a remarkable way, considering the challenges that there were none for these sites when they began. After 2 years, they've made astonishing progress. They've developed some regionally appropriate clinical management guidelines. They've begun skills development for on the ground in all the respective sites, and they're planning for cohort studies and to initiate programs in newborn screening, infection prevention, wider hydroxyurease, and database expansion. They've agreed on the database elements, phenotype definitions, and ontologies, as I said, and this can be, you can see the World Wide Web site where you can actually look at what they've developed, and they are very sophisticated data elements that are state-of-the-art for anywhere in the world. The centralized database is established, and they're in the process of trying to expand back up on the system, but otherwise the software is very well developed. They've completed all regulatory approvals for the database, and now they're already well along towards their target. And in fact, at 2 years, in April of the funding of 4-year grant, they were already over halfway with 6,500 plus recruits, slightly over halfway. They've also done multiple workshops, as shown in this pictorial here, with site visits to the respective places in the 3 countries, as well as meeting together for data management workshop in Abuja in 2018. So some of the accomplishments I've already alluded to. They've linked up with the H3 program, which H3 BioNet. So the idea is that ultimately we'd like to see these 3 programs harmonized in a way that so that there's, even though their funding line streams are different, they will all crosstalk so that as we can develop programs across all the 9 countries now, and then other countries that we hope to expand to in the coming years. The definitions will be shared across these, and then there are links to other ontologies that have been developed already here in the U.S. and in Europe, including Phoenix, MESH, SNOMED, and other worldwide accepted high-quality data sets. They have a well-developed database that's being expanded as we acknowledge, and they facilitate, this is already facilitating data sharing and allowing them to develop exploration of new scientific questions, and they've incorporated regionally appropriate terms and definitions for each of these. There are still challenges, of course. Enhancing cooperation among these NIH-funded investigators needs to be continuously and judiciously encouraged, and it is. Incorporation of hydroxyurea from the use from the REACH study is ultimately, the plans would be that what's learned from this study will be incorporated into the other components, and that standardized phenotypic and ontologic databases will be developed. And then bringing the investigators, some of whom the pictures are shown below, are still a problem. They're still a challenge, but they're making steady progress. Finally, on my last slide, I wanted to say that the 13,000 number is achievable. Already, in fact, well, 13,000 is already an accomplishment because 5,500 have been recruited in Sickle Gen. REACH has recruited their requisite 600 children on hydroxyurea, and 6,500 have been recruited for SPARCO and SADAC, with anticipated amplification to another 6,500 by end of March 2021. so that the total numbers will be close to 20,000 at that time. And the idea is to continue that recruitment beyond that with appropriate funding mechanisms that are presently being developed. You can see all the activities summarized below. I won't go through them, and you can see the relevant places where these studies are being performed. But I want to emphasize, as my last component, is that training is an important piece of each of these programs, and there's an important link of collaboration with Fogarty here at NIH with each of these programs, so that young investigators can be taught both on the ground in Africa, but in some cases where it's appropriate, they can be brought here to NIH to receive specialized training. So with that, I'll conclude, and I'll turn it over to Cheryl Boyce.
Thank you for that perspective in terms of the real world, in terms of our global world. And now I'd like to share a little bit about some of our domestic efforts, primarily related to implementation science and our Sickle Cell Disease Implementation Consortium. The Sickle Cell Disease Consortium is an effort that is based in 8 sites, both rural and urban, ranging from sites in Chicago, North Carolina, Washington University School of Medicine, in St. Louis, New York, Memphis, South Carolina, Florida, and all these sites together are coordinated so that we can have an opportunity to make sure that we have a collaborative effort by the RTI International group. The goals of the consortium are to develop a registry in collaboration with other centers and the NHLBI, as well as a needs-based community assessment of the barriers of care for subjects with sickle cell disease. We also want to design implementation research studies that address the identified barriers to care. And in doing that, we have a couple of phases to the study. The study has in its need assessment a couple of topics that really look at hydroxyurea, pain, quality of care, and emergency department care. These are all topics that really are important when it comes to really bringing what was found in our evidence-based assessment of what's needed for implementation from our guidelines. And we're using methods in terms of surveys, key informant interviews, focus groups, a mixture of qualitative and quantitative methods. The idea is to use implementation work groups that come up with an implementation design using the best frameworks of implementation science to both think about how to redesign care to improve it, how to improve the care that's within the emergency department, and also to find those patients who are not affiliated, who really aren't getting continuous care, getting the best prevention and treatment efforts, and bring them in to treatment. These are often unrepresented in previous efforts, in previous studies, and prevention. Now, in terms of some of the surveys, they're both from patient-providers' perspective, so it's really a multi-level approach to implementation. And we find that that's really the best way to bring things into a strong implementation effort and also a multi-method approach. The registry is focused on sickle cell disease from 8 centers, and we're using standardized tools. And we're really pleased that at this time we have almost 2,400 patients, 300 from each center. And getting these patients in the registry is ideal because we are able to, of course, bring forth in the registry efforts from other registry efforts, including that one that you'll hear about in our next talk. Now, in terms of inclusion criteria, it's also important to note that we have a broad age range. What we find is that young adults and adolescents are often left out as well. There's this gap in care for that population, and it was really important to make sure that recruitment included that population in terms of this study. In the first study, which is really looking at implementation design, some of the barriers are really not taking hydroxyurea, and this is one of the evidence-based treatments that's really important in terms of care. And using technology, an intervention is using an app with implementation studies to increase adherence to hydroxyurea. At the provider level, there's a companion app that's also being used for implementation strategies. For the second study, in terms of emergency department care, similarly, there's multiple levels. In terms of the patient, the emergency department provider, and then thinking about the patient-provider levels together, we're looking at the emergency record and how to really get in touch with that, both of them together in terms of looking at the diagnosis, managing pain, which is often the concern when coming into the emergency department, and really increasing self-efficacy when a patient comes into the emergency department with pain, and making that experience one that will really bring a patient a satisfactory experience in managing their pain when that's necessary. Now, perhaps the most difficult is the unaffiliated patients. These are the lost patients, and really a population that has been underrepresented and untreated previously. And they can only get care when they come into emergency department, and often when the pain is severe. And bringing them back into care is something that is a large goal of the implementation study. And defining who these patients even are has been an important process in using a Delphi method and using experts, including some of those from the NHLBI original guidelines. And we have actually come up with a definition, understanding what's really routine care and what's not routine care and who's an expert. So together we have now 3 studies that will really look at implementation across the population to better understand implementation science strengths, understanding the barriers to care, and also understanding how we can best understand those barriers and design research that will unpack those barriers both at the patient and provider level and bring forth new strategies that can move into the real world of the patient and provider community. And with that, I'll turn it over to our next speaker.
And our next speaker is joining us remotely, so if you give us 1 second, we'll...
While Darian is switching over to Dr. Kim Smith-Whitley, for her presentation, I just would like to remind everyone that using the chat feature, which should be at the top of your screen, you can open that up, scroll down and press host and presenter and insert your question there. Thank you.
You can pass.
You.
While we're getting this, oh, go ahead. I was just going to welcome you.
All right. Well, thank you. I just like to thank everyone for including SCDAA in this initiative and for inviting me to speak on Get Connected, an information sharing network and patient-powered registry for children, adults, and families living with sickle cell disease. For the remainder of this talk, I'll be primarily representing the Sickle Cell Disease Association of America, I should say America there, and as a board member, as we work towards developing what I hope will be a sustained initiative for sickle cell registry. If you advance to the next for some reason, thank you. So we understand that there have been many advances, many of those sponsored by NIH in clinical care. We have infection prevention, we have stroke prevention and pain prevention with hydroxyurea and other agents now. We've improved the understanding of the underlying pathophysiology of sickle cell disease as well, yet morbidity and mortality remain high. Although we have hydroxyurea and L-glutamine, we really have few disease-modifying therapies. We have limited access to sickle cell expertise for those living with sickle cell in the U.S. We do not have a quote-unquote universal cure. Although we have transplant, we often do not have bone marrow donors that are appropriate. And then many of those living with sickle cell disease in the U.S. still have poor access to high-quality care. And it's particularly challenging as we transition from pediatric to adult-focused care, and also the silos in individuals who may not be cared for in large urban centers. Next slide. So we, at the Sickle Cell Disease Association of America in late 2014, tried to think about ways of improving our programming that could support increased access to high-quality health care across the lifespan, support drug development therapies and programs that improve the quality of life and decrease disease-related complications for those living with sickle cell disease, and then to search for cures with low-risk profiles accessible for all people with sickle cell. Next slide. In an effort to do that, the board was really struck by the fact that in late 2014, we did not know where many individuals with sickle cell disease were living in the U.S. and whether or not they were receiving high-quality care. We had the 2014 NHLBI expert panel report, and it wasn't clear whether or not those providing care for individuals living with sickle cell disease had access or knowledge about that report. And so they really wanted to find a new infrastructure to provide good information to children and adults living with sickle cell disease, really to look at a way of also giving their providers access to information like the publicly accessible NHLBI expert panel report, and then to improve efficiencies in the sickle cell community by providing a common pathway for communication between various stakeholders such as individuals living with sickle cell disease, providers, community-based organizations, and those and organizations that are interested in improving the health care for those living with sickle cell. Next slide. So the board decided to embark on a project that could establish a network of children, adults, and families living with sickle cell disease and sickle cell trait, Sickle Cell Disease Association of America member organizations, healthcare providers, community-based organizations, in a way that with this network, it would facilitate the distribution of information related to clinical care, research, health services, health policy, and advocacy. And to establish a registry for children and adults living with sickle cell disease for storage of medical information related to their diagnosis and treatment, and develop an online community for information sharing and psychosocial support. And on the next slide, it just highlights the one that I'll be talking about today. The primary goal and objective is for this establishment of a network. And we're hoping that maybe in another session we can talk about the registry and how secure it is and how it allows safe storage of information, and then the future of developing online communities for psychosocial support. But today I'm just going to focus on establishing this network. And of course the purpose was to develop a high quality resource of information, so to develop a committee that would be simply developing the messaging for the Get Connected infrastructure, which is what we decided to name this network, and to develop this infrastructure in a way that allowed for sound information dissemination, education, and communication. Next slide. So Get Connected is SCDAA's version of this information sharing patient-powered registry that develops information and messaging about clinical care research, health advocacy issues related to sickle cell disease and sickle cell trait, and allows storage of health information so that individuals can better navigate the healthcare system. Next slide. The way that you can access Get Connected is through the Sickle Cell Disease Association of America's website. Next slide. You can see that this has recently been upgraded, and if you look on our website at the top, it says About Us and Sickle Cell Disease, and on the next slide, you'll see if you click on that sickle cell disease, the drop down comes down and you can get onto the Get Connected site through SCDA's website. And on the next slide, you can see the introduction to the Get Connected patient-powered registry. By top, it says that if you register on this secure network, you can get information about sickle cell disease, stand up, and be counted as a member of the community. Next slide. I think what is really striking about the Get Connected concept is that many individuals can participate. You can see on the bottom of this slide who can use Get Connected. Well, remember, it's all stakeholders, so it's not just individuals with sickle cell disease and their families, but also members of SCDAA, healthcare providers, clinical researchers, advocacy organizations, and children and adults living with sickle cell trait as well. Because in addition to really trying to challenge where are people with sickle cell disease living, are they getting good care, but also how can we engage those living with sickle cell trait to also be a part of the community so that they can share information about sickle cell trait, sickle cell disease, and also participate in advocacy issues. Next slide. With this Get Connected registry, the second thing that is very important is it allows the individual to opt in or opt out for receiving certain information. So you can go into the Get Connected registry, you can register as whatever stakeholder member you are, but you can then select that you choose to get information about sickle cell disease and self-care, clinical trial updates, awareness and advocacy, disease research, trait research, so that if you are particularly not interested in getting certain information, you can then opt out. The other thing that it provides you the opportunity to be connected to a Sickle Cell Disease Association of America member organization, and that is an opt-in. You have to actively click that toggle in order to be connected to a member organization, and subsequently they could reach out to you. Next slide. The thing that has been, I think, very, very important for us as an organization is the Get Connected Committee that's led by Dr. Sue and Dr. Anna Merriam. And they are instrumental in developing their messaging for Get Connected. This is one of the first things that went out about sickle cell trait testing and whether or not the Sickle Dex or solubility test were the correct test for really providing information to families of those living with sickle cell trait. So our Get Connected messaging looks at disease self-management skills, preventive care, sickle cell complications, clinical trial participation and summaries, advocacy and awareness initiatives, health systems management, behavioral health management, transition such as preparing for college, sickle cell trait, talking about what is blood in the urine or hematuria, and then Get Connected updates, what's coming next for our Get Connected community. Next slide. We were very fortunate to be awarded a HRSA grant that allowed us to also use a beta test for the Get Connected registry. And on the next slide, you can see that this 2-year project focused on creating a national effort to develop, implement, and maintain a strategy to identify and assess the care quality and outcomes of individuals with sickle cell disease in order to provide improved access to comprehensive care, to increase the use of community health workers and increase the number of individuals with sickle cell disease who had care coordination and follow-up and referral to medical homes. Next slide. Through this initiative, we were able to really look at our ability to use the Get Connected infrastructure in a way to say that we reached out and touched that individual and then got that individual into care. There were 26 member organizations or community-based organizations in 20 states and 5 HRSA regions that participated in this project. Next slide. And you can see that within 18 months through that network, 4,000 individuals living with sickle cell disease were enrolled in our Get Connected registry. That was kind of an example of what Get Connected Deep was, because that was a very, very comprehensive program. And we've now switched back to a Get Connected Lite, where you can just actually simply go through either initiatives through member organizations or just from the comfort of your home, getting onto a computer and enrolling and Get Connected without needing to go through all of the different initiatives that were involved in the HRSA project. But it just shows the power of what community-based organizations can do in enrolling and reaching out and touching individuals with sickle cell disease and sickle cell trait. And on the next slide, you will see our current enrollment in Get Connected. There are currently 6,329 enrolled in the Get Connected registry and information sharing network. Of those, 5,100 are children and adults with sickle cell disease, and 52% are adults in that portion. Children and adults with sickle cell trait, with 64% being adults in that group. And then in non-patients, we have providers, members of advocacy organizations, SCDAA member organizations that are also enrolled in the Get Connected registry. Next slide. So with that, I hope that I've given you an overview of SCDAA's Get Connected information sharing network and registry. We're hoping for future directions that we can generate reports so that we can inform policy as we move forward by grouping information in disease-specific areas by state, expand information dissemination platform to support clinical trial awareness, and engage new partners and work with hopefully NHLBI and others to try to figure out ways to engage the sickle cell community in clinical research projects. Next slide. I really need to acknowledge all the people behind this work, and that includes our Executive Director, Beverly Francis Gibson, who leads the efforts from SCDAA, along with Ola Fajobi, Carol Bernard, and Natasha Thomas, who work with Louis Sue, Berea Demiriam, and Gwendolyn Poles, along with Dr. Whitney Sherney on the Get Connected messaging and strategy. Of course, we could not have done this without our member organizations and all the children and adults living with sickle cell in the U.S. And hopefully Get Connected will continue to exemplify work as we move forward to find healthier ways of caring for individuals with sickle cell disease and sickle cell trait. Thank you.
Thank you so much, Dr. Kim. Ms. Whitley, for that presentation. We're now going to take a few questions that we received via the chat. Dr. Hook, you shared the growing use of hydroxyurea in Africa. Is its use in the U.S. similar?
Well, first of all, I think the use in the U.S. in children is high, relatively speaking. It's I won't give you a percentage, but it's relatively high. It's in adults in the U.S. where the use is challenging at best, because numbers such as 20%, 25% are in the published literature for adults for a number of reasons, both related to access to care, some claims of side effects, some just resource capacity or access to resources. So that's the situation in the U.S. In terms of Africa, the one study, the REACH study, the adherence to the drug was remarkable, beyond any study I've ever seen anywhere in the world. Again, these were children where the parents took full responsibility for making sure they took the drug, came back, were assessed, continued to take the drug, and it was above 95%, which is a testament to the investigators and beyond any adherence model that I've ever seen anywhere in the world.
Wonderful. I'll ask this to all three panelists. A lot of folks want to know how to get involved and how they can help. If we can start with you, Dr. Boyce.
Well, I think one important thing is to consider clinical trials. And if you go to clinicaltrials.gov, you can see the clinical trials that are available in your area. One thing that was important, as Dr. Hoots just expressed, is that there's really not great percentage of use in terms of hydroxyurea, which we know is evidence-based treatment, and that people stop use and maybe due to side effects or pain or many different reasons, and we don't always know why, so we can't really improve drug treatments or figure out ways for different treatments or integrative treatments. So it's really important that we get better data and try to really design the best treatments. So we really are asking people to consider engaging in clinical research as much as possible. That's a very important part of science and implementation science, and getting the best evidence that we can use to design the best treatments.
Dr. Smith-Whitley, is there anything you would like to add on to that?
Yeah, I think I agree. I think that that is going to be key to make sure that research continues to move forward. And I think that one of the ways that we can do that is also through sickle cell awareness. I think that when you look at sickle cell disease, it really embodies one of the disease entities where there have been health disparities. And we really need to improve awareness. We know that the first individual with sickle cell was described in 1910. And we need to ask ourselves what we can do to make sure that the therapies that have been developed, largely through NHLBI and NIH, can get to the patients that deserve high-quality care. So whatever we can do that increases access, improves our ability to develop disease-modifying drugs and curative therapies, I think will come through awareness and advocacy as well, and then developing an infrastructure to disseminate the information once we have it, to make sure that providers are informed and that patients are informed about what high-quality care is.
Thank you.
I'll just add on to that with regards to Africa. I mean, I told you what the remarkable participation rate had been with REACH. I think it emphasizes something that is true in developing countries where people have not traditionally had access to care or therapies in the same way that we have in the developed world. And I think the reason we're doing research is because we're trying to build infrastructure, because we think you need to be able to demonstrate that what is true in the developed world is also true in the developing world. And in the process, participation may lead to better care, and the ethics of the situation require that if you show efficacy, like they're showing in REACH in that New England Journal article that I showed you, then it's incumbent on the investigators and societies, both in the developing and the developed worlds, to try to work with the government entities to make sure that those therapies can be maintained even after the studies have closed. So that's another big challenge, but it's a really important challenge. What we don't want to do is prove that it works in places where resources are limited and then take the resources away and have children or adults not have access to the proven therapies.
And Dr. Hoots, you also mentioned that there are training opportunities for investigators. Is there a website where they can access that information?
Well, there are a number of websites. I would say Fogarty International Center is the place to go first for investigators who are looking for who are in international sites who are looking for opportunities. The investigators in the programs that I discussed outside of poverty, those are targeting only the sites where we are funding. And then obviously for investigators within the U.S. Who are looking for training opportunities in international health and sickle cell, then contact us through the NHLBI website, and grant opportunities can be discussed, because there are a number, depending on the level of experience that the young clinical or basic science investigator has.
Thank you. And then we have one more question. All three speakers mentioned registries. Will these registries be compatible with each other? Is there collaboration among them? And I'll allow the speakers to jump in.
I'll start. I think that's the overall intention. It's not as easy as it sounds because they are, oftentimes the respective registries are coming at it in multiple ways, as you've already heard today. That's why things like ontologies are so important, so that the definitions that are used in one registry are common to ones that were used in other registries, so that when you want to merge the data with permission from the participants in the respective registries, you can do it. And that's what we're trying very hard to do, is bring all the players together on an ongoing basis to ensure that as the data is collected in multiple registries, that we can build a common crosstalk that will lead to, at least here in the U.S., a larger registry of registries where the information can be consolidated in a way that's not possible at the present time.
Thank you, Dr. Hoots. And those are all of our questions for today. Lenora, if you would like to take us home.
If you still have remaining questions on any of the topics or any of the presentations made, please be sure to send them to NHLBI News in EWS at nhlbi.nih.gov. Again, that's NHLBI News at nhlbi.nih.gov. In addition, we want to make sure that you continue to join us, register now, for the upcoming webinars for Webinar Wednesday throughout the month. The next one next week will speak to genetic therapies in the area of sickle cell disease. Following that, we'll deal with other types of research innovations that have addressed sickle cell disease, such as bone marrow transplant. And then the final will be sponsored by the Department of Health and Human Service, and we'll talk about emergency department innovations as well as pain control. So we invite you to tune in for those. We do recognize that some had some technical difficulties toward the end there and weren't able to see the slides. So please do reach out. We're happy to share the slides more broadly for those that were unable to track through. With that, thank you for joining us today, and we look forward to having you back with us next Wednesday. Take care.